So thank you very much for coming. I'd like to start with acknowledging the traditional custodians of the land we meet on today, and that for me, that's the Gadigal people. And I'd like to pay my respects to elders past and present and extend that acknowledgement and respect to any Aboriginal and Torres Strait Islander people that might be joining us today. So a bit of housekeeping. It's a little bit of different housekeeping when you're doing a virtual presentation, so I don't need to let you know where the exits are and where the bathrooms are. You'll already know that. But there are a few things that I do need to let you know. But before I do that, I'd actually like to thank a few people that are in the room today and perhaps some that aren't here as yet. We did actually have a working group to sort of really make sure that what we were delivering today really hit the mark, and they were basically from heart units of various LHDs. So I'd actually like to thank Kevin Schamberg from Murrumbidgee and Southern New South Wales. I'd like to thank Megan McDonald from Hunter, New England, Franklin John Leader and Krista Zorab from Mid-North Coast and Northern New South Wales, and Louise Mayer from Nepean and Blue Mountains. But I'd also like to thank Heart Managers who have been very supportive of actually us getting this off the ground. And that's Anne Ryan, Megan Brooks, Alison Nakatis, Felicity Sheaves, Jen Heslop, and Melanie Kingsland, sorry. So thank you. And so the other things I wanted to let you know that you will be put on mute, as you know, so you're mute already. And we encourage you to actually put questions into the online chat. We'll endeavour to answer those as we go. Kyle and Ruth will be personing the chat line. We do hope to have some time at the end to actually to chat and get the questions live. So we're really hoping that we can achieve that as well. And anything we're not able to answer, we'll actually get back to you in the coming weeks. We also, not coming weeks, the coming week. We also will be sending an evaluation survey out today. A little via Eventbrite will actually happen after this meeting. So please look out for that. Really important you give us feedback. It really basically will fine tune what we do. And again, we're actually going to seek for additional topics and areas of interest. So this isn't the first, this is the biggest one that we've done on a statewide scale so far during Hepatitis Awareness Week, which is absolutely fantastic. But we will be doing more of them. So any feedback that you can give us will be greatly appreciated. So thank you. So as the peak body of hepatitis in New South Wales, this World Hepatitis Day, which is on Tuesday, and Hepatitis Awareness Week, represent a really great opportunity, but also very heartfelt for us, and because it provides us an opportunity to amplify our voice and advocate for people affected by viral hepatitis. And I'm going to take a bit of a shift of dialogue now, but coronavirus, and I know that we've all heard a lot about coronavirus, but since the first case in Wuhan on December 31, and it's been very prominent. It's been very prominent in the media, and you know, it's caused a whole lot of chaos globally. Interestingly, World Health Organization has identified 28 myths that actually perpetuated around the world around coronavirus, and they've actually on their website aimed to debunk these 28 myths. And some of the myths that you're familiar with about, you know, coronavirus being spread through 5G network, you know, they're very elaborate, they're very creative and imaginative sort of myths and things, but often a lot of it is very much fear-based as well, and it's basically misinformation and to some extent, you know, a fair bit of ignorance as well, I'd say. So there's a little bit of an overlap there in some respects with hepatitis C, and certainly when I say that, I'm not talking about the virology of the virus at all, but I'm talking about some of the misinformation, some of the myths, and some of potentially the confusion and fear that also exists around hepatitis C. And today, we're going to sort of demystify some of those things and really make sure that we get the true messages out there with regard to access to treatment, as access to testing and treatment. So some of these myths in terms of with coronavirus, basically, as you know, are actually held at all levels of society, from heads of state, global heads of state, right through the general populace. Similarly with hepatitis C, some of these misunderstandings and myths, if you like, again, are actually held at all layers of society, from government and also to those most affected, people actually living with viral hepatitis. And particularly people who are most at risk of hepatitis C, and that is basically people who inject drugs. So these fears and misinformation really arise from stigma and discrimination, portraying people living with hepatitis C as people worthy of contempt and blame and conscious and unconscious bias that often we demonstrate towards these people. There's a legacy from interferon treatments, certainly. And all these things collectively basically create significant barriers to the people accessing testing and treatment. So as I said before, today we're going to provide the facts, the real information, and what we're going to try and do, try to provide a general education session that's applicable. So it's the need to knows for anyone really working with anyone at risk of or living with hepatitis C. So I'm really delighted to be with my colleagues today. So the presenters that you have for the next 1.5 hours, or a little bit less than that because it's now 2:12, is Ruth Bearpark. We have Alex Ryan, who's also looking after tech, Kyle Leadbeater, and Justine Deutsch, JD. So that's all from, oh, it's not all from me. I do have one more thing. Alex, second slide, please. So this is the things we'll be covering today, but in short, the pathophysiology of hepatitis C transmission, testing and diagnosis, the new DEA treatments, stigma and discrimination, and then I'll come in again and with some take-home messages and just a session close and hopefully some time for some questions. So without further ado, I would like to hand over to Ruth Bearpark. Thank you.
Hi everybody, and lovely to see your faces and names on the boxes here. My name is Ruth Bearpark and I'm the Health Promotion Coordinator here at Hepatitis New South Wales. I know as well that we're speaking to some people who have been working in the sector for decades and other people who are coming to this topic for the very first time. So, the conversation that I'll be having with you over the next few slides is really about a basic overview of the liver, the virus, and how to test for it in a way that we can have conversations with our clients and communities to really engage them. So it's a conversational discussion that I'll be having with you. So next slide, Alex. Thank you. Well, I think Sandy was going to talk to that one.
Yeah. Okay. So I'm just going to talk very, very quickly about prevalence and treatment uptake. So currently in Australia, there's just over 130,000 people living with hepatitis C. We've treated essentially over just over 74,000 people have actually received antiviral treatment since the introduction of the new treatments in 2016. That leaves 39% of people living with Hep C have been treated, and that's a national picture. On a statewide picture, 48,000 people in New South Wales, 34% are cured, the target is 40%, and 4.1% have received a second course of treatment. And that is a result of reinfection, but also a result of sometimes people stopping their medications. There's a variety of different factors that contribute to that. Interestingly, Tom Wright from Justice Health was talking at our event on Tuesday, and Tom said that currently, in the first 6 months of 2002, that 1/3 of the treatments of people that are in custody are retreatments. And that doesn't actually take into account the people that may have been treated outside of prison, that were actually treated in community before they actually went into custody and then potentially retreated again. So that's really a very, very, very high amount. about 25% of all the people who've been treated for hepatitis C are in fact people that have actually been tested in the criminal justice system. Next slide, Alex, please. So these are our elimination targets. We want to eliminate hepatitis C by 2028. There's 3 targets to achieve elimination. So 80% people with Hep C into treatment, 80% reduction in new transmissions, and 65% reduction in Hep C related deaths. We've done really, really well in Australia with getting people into testing and treatment, which is absolutely fantastic. But the highs that we saw when the GAAs were first released in 2016, early 2017, the numbers of people accessing treatment and treatment initiations each month have actually declined quite significantly. And looking at a New South Wales perspective, the last data that I've looked at is around about 400 initiations each week. So we've been very, very successful, but we do really need to work together to ensure that we actually do reach these elimination targets by 2028. So there is a bit of work to do, and we do need to actually, because obviously COVID has actually interfered, there's been less opportunities for outreach. We need to get people re-engaged in testing and treatment. We need to be innovative, creative, come up with some really great ideas, work together to enable us to do that. So Ruth, I'll hand over to you now.
Thanks, Sandy. Next slide, Alex. Okay, so as I was saying, I understand that we're all coming to this with different levels of understanding of Hep C, and this is really about how we can engage people in conversations around Hep C and the liver. So really, when we're looking at hepatitis, we can start with pretty much the organ that it's affecting, and if we understand that that it's about the liver rather than this kind of nebulous Hep C thing that we talk about, we can perhaps internalize it or understand it a little bit better to support people to feel self-motivated to do something for themselves. So the liver, where is it? It's, and I was told that I should stand up. So it's here, right? It's on the right-hand side of your body, and that's where it's sitting. And it's doing, you know, it's got 500 jobs, and it's doing all of these right now at this very minute. What it's doing is it's, first of all, it's this beautiful sort of squishy, spongy organ that filters 1.5 litres of blood per minute. When I first heard of that statistic, I can't even drink 1.5 litres of water per day, and my liver is pumping through 1.5 litres of blood per minute. It's a lot, and what it's doing with that is it's filtering that blood, it's turning carbs into sugars for energy, so it's storing sugars for later or energy for later. It breaks down all the toxins that we pour into our bodies, so pretty much everything we consume gets somehow unpacked and sent out to different parts of the body or disposed of if it's a harmful toxin. And it manufactures a whole range of different substances. Here's just a few. So it creates bile to help digest fat. Interestingly, it creates bile from some of the toxins. So it's kind of this, you know, eco-friendly kind of chemical plant that we've got sitting in the body. It's also the biggest organ inside our body, and it does all of this without really letting us know what's going on. I think this is something that can help to communicate and engage our communities around hepatitis C, is for people to understand exactly what this organ is doing for us. So it, you know, cholesterol that helps create certain hormones, and albumin that is a protein in our blood plasma that helps to regulate water balance. I mean, they're just a few things, but if we think about the 500 jobs that it's doing and the knock-on effect in our body if it's not able to do those jobs. Next slide, please, Alex. Oh, one before that. Thank you. So that's that beautiful pink squishy huggable looking liver that you just want to kind of get your fingers into and give it a squished, and you can imagine if you did that, that it would be juicy, there'd be lots of blood everywhere, and that other organ sitting underneath it is one that has a lot of scarring. It's got some tumours there as well. It's really hard and knobbly, and if you think about the amount of blood that's being pumped through the liver, it would be really hard for that blood to be to flow through an organ that has that amount of scarring, and that's what we're trying to prevent. There's a whole range of different things that can cause scarring of the liver. So we might go to the next slide, Alex. So what are some of the things that can cause that? So hepatitis. And so hepatitis, if we break that word down, hep is liver, itis is inflammation, and then we've got all these different things that can cause an inflammation of the liver. So an inflammation of the liver can be caused by certain drugs, different viruses, long-term heavy alcohol use, autoimmune diseases, a whole range of different things. And when I say certain drugs, I don't mean illicit substances or street-based drugs. That quite often they're over the counter. Could be a heavy course of antibiotics that somebody might be on, some pain medication, whole range of different things that could be causing, because a lot of these drugs are also metabolized in the liver, so it can inflame the liver. So there's all of these things, plus there are some viruses like hepatitis A, hepatitis B, hepatitis C, and that's the focus for today. I think when people talk about hepatitis, they immediately jump to Hep C, but if we can maybe detach that sort of social construct from what hepatitis is and look at it for the health issue that it is, rather than the assumptions of what has caused this inflammation. You know, I think we have a different reaction when someone tells us that their tonsils are inflamed, if they've got tonsillitis, or if they've got hepatitis, is different from if they've got appendicitis, just as examples. Okay, so next slide, please, Alex. So what is Hep C? So it's a virus. We all hear a lot about viruses at the moment, and this particular virus is a virus that comes into our body, and it uses the liver or hepatocytes to replicate itself and infect other hepatocytes. On this slide it says that the virus is slow acting and symptoms may not appear for many years. And I understand what that statement means, that actually the virus replicates very, very quickly, but the liver cells are damaged slowly over a period of time. So so the symptoms or the feeling or the damage can happen over decades, and can be something that people might put off as well because they're not feeling or seeing the damage that's being caused. So yeah, if it's not treated, if it's untreated, it can lead to severe liver damage, cirrhosis, which is a lot of scarring. The good news is it's easily cured. These days it's easily cured, and I guess this is these are some of the things that we need to really communicate to our communities and our clients, is these are the facts of hepatitis C. These are the facts of hepatitis and of liver disease that we can easily communicate in some simple sort of bullet points there. Okay, next slide, please, Alex. So this is sort of just a drawn image of how it might look, that you've got that lovely squishy pink liver on the left there. Now, and these are the terms that are used in healthcare or in clinic around how to define the level of scarring in a person's liver if they've been living with Hep C for a while. So you've got your healthy pink squishy liver on the left there. Fibrosis means that over a period of time, the liver cells have died or been damaged from the Hep C inflammation or infection, and there's been some threads of scar tissue. Over a period of time, the more scar tissue there is that can kind of web together, then the denser that scar tissue becomes, and it moves from fibrosis to cirrhosis. That is just a spectrum. They're not two different things. It's a spectrum of scar tissue. And that damage can, over a period of time, because the cells are changing and are damaged, can lead to some liver cancer and can also lead to liver failure or decompensated liver. This also looks like it's in a clean progression, and people and human bodies are not so neat and tidy. So some people can be living with Hep C for a long time and not have any liver damage at all, and other people can be experiencing a lot of liver damage even though they've been living a fairly healthy life apart from their Hep C infection. Okay, next slide please, Alex. So, all right, so how do we get Hep C? How is Hep C contracted? The virus is very specific. It can only move in blood. So when we think of viruses, or when I think of a virus, I always think that it's this entity that, or like people, I guess we need a vehicle to move from point A to point B. And viruses are the same. They always need a vehicle to move from one host to another host. I'm pointing to you guys in the pictures on the screen here. So Hep C only uses blood. That's the only vehicle that it uses to move from one host to another. If somebody is exposed to the virus, if the virus enters into their bloodstream, they've got a chance of clearing the virus spontaneously. So there's about 25% chance of that clearance. There's no real reason why that might happen. It could be that maybe the virus was a little bit old when it entered into the bloodstream, so it's weak, and our immune system was able to overcome it. It could be that maybe there wasn't much of the virus there, so it wasn't able to replicate. Clearing the virus, if you do spontaneously clear it, doesn't give you any immunity at all. You're just as likely to contract Hep C again in the future, and just as likely there's a risk of developing chronic Hep C, which is defined as having Hep C for longer than 6 months. Okay, next slide, please, Alex. So I think there's no surprise here that most people who contract hepatitis C have contracted hepatitis C through sharing injecting equipment. That could be a whole range of different types of injecting equipment. And that could be, you know, maybe an experience that somebody had back in 1972. That's how they contracted Hep C. Or it could be more recently. It could be also that about 10%, maybe less these days, are people who, people from high prevalence countries so I think Egypt still has the highest prevalence of hepatitis C in the world. There's some other countries that have really high prevalence. The more Hep C there is in a community, the more likely it is that that person can be exposed to the virus. So what about these other transmission routes? Here at the bottom of the slide, 6.8 are via other transmission routes. Well, what are they? Let's have a look. Next slide, please, Alex. So just a list here that unsterile piercing or tattooing, kind of a good way maybe to start engaging a conversation with somebody around Hep C, you know, because tattooing is really popular these days. Kind of showing my age, I guess. I don't have any tattoos, but just to say that that it's I guess a way to say, hey, you know, fantastic tattoos. Here's some information about sterile tattooing practices and getting tested and treated if that exposure happened when you were getting it, like in countries that might not have strong sterile tattooing procedures. Recipients of blood transfusions before 91. I remember someone saying to me, you know, I had a blood transfusion, but I didn't know that I had a blood transfusion because I was so unwell at the time. They'd had an accident, so they didn't know that they'd had a blood transfusion because they were unconscious, being treated at the time for for this accident that they'd had. So maybe that's another way of engaging people around Hep C conversations. Performance and image enhancing drugs, so steroids, breakdown in infection control procedures, needle stick injuries, for example, really uncommon for that to occur for Hep C transmission. Men who have sex with men who are living with HIV, very small cohort who are very well connected with health services usually, and it's very specific, them sort of machinations that might happen there. And there's some really fantastic health promotion messaging coming out of Positive Life and ACON around how some of those strategies can be, employed in different circumstances to minimise the risk of transmission. And babies born to mums with Hep C, really low prevalence, about 4 to 7% of mums of babies born to mums with Hep C will develop Hep C after birth. So a really awful time for a mum to be dealing with that, I guess, news, and needing extra support around what those choices are for baby and mum. Next slide, please, Alex. So how can you tell? Really, you can't. So these are some of the symptoms that people talk about with Hep C. But who goes into their doctors and says, you know, hey, I'm feeling a bit tired, so I think I might have Hep C. So it's not one of these health issues that people will present because of their symptoms. This is why it's really important for us in the sector to be actively encouraging people to get tested rather than expecting people to get tested because of the symptoms they might be experiencing. Also, a lot of these symptoms might be sort of growing over a period of time, so people will put it down to aging rather than an infection like Hep C. Next slide, please, Alex. Thank you. So who to encourage? Look, there's a whole list there, but I encourage anyone who doesn't know their status to get a Hep C test. If you don't know your status, then it would be great to encourage that testing. And I guess it's really about sort of where your communities or clients could access that testing as easily as possible, and for you to know where to refer your clients and communities, or even to have, say, in-reach type services in your service where testing is available within the services that you're already providing. A little difficult in the times at the moment, but Alex will be talking on new testing that can be done at home. Okay, next slide, please, Alex. Okay, so this is the crunch of how somebody is diagnosed with hepatitis C. So there's two tests. One is an antibody blood test and the other is an RNA blood test. So when the virus enters into the body produces antibodies. So our immune system produces antibodies and tries to swarms the virus and tries to overwhelm the virus, kills it off, sends signals to other parts of the immune system to come along and kill it off. They work really hard, these antibodies, but they're not that effective. That's why like 25% of the time we might spontaneously clear it, but most of the time we don't. So, sorry, I've realised that what I'm doing is I'm pointing to the screen as if you can see it. So those little Y symbols, they're meant to be the antibodies. And so they're coming in to try and attack the virus. So the antibody test is only looking for those antibodies, right? If they're detected, then that means that you've been exposed at one point to the virus, or it could be that you're in a 12-week window period. So if your antibody test comes back reactive, then that means you need to get a second blood test. Sometimes that can be quite traumatic for someone who doesn't like to get blood drawn. So it could be that you might have, I think it's called a reflective test, where if that antibody test comes back reactive, then the RNA is automatically performed. And that RNA, you know, we have DNA, so viruses have RNA, right? So that's looking for the actual virus in your blood. If that comes back detected, that means that the virus, they've detected the virus in your blood. I kind of hope that one day we could get rid of the antibody test altogether, because really the information is in the RNA, and that's the only test that can diagnose somebody with a current hepatitis C infection. Okay, look, I'm going to hand over to Alex now, that's going to be talking about a new test called DBS. Alex, handing over to you. Thank you.
Thank you, Ruth. Hi everyone, I'm Alex Ryan. I'm with the team here at Hepatitis New South Wales in Health Promotion. I'm a part of Ruth's team. Thanks, Ruth, that was great. What I want to talk about just briefly is the dry blood spot test. And some of you might be familiar with the dry blood spot test, may have already been using it in the work that you do in our community. I think what really struck me in what Ruth and Sandy were saying was just how treatments for hepatitis are dropping off. And just looking at the numbers, I think it's been like a 30% reduction since from 2018 to 2019. So in 2018, there was something like 16,000 people treated for hepatitis C. And then in 2019, it went down to 11,500. So I think that the other thing that struck me this week from the World Hepatitis Day talk was that in the future, we're moving more towards RNA testing and really focusing on RNA testing as a way. Greg Dahl was saying that in his talk at looking at active infections. And the dry blood spot test actually does just that. It looks at the active Hep C infection that a person currently has. And it's a great tool to be able to use in our services for lots of different reasons. So I'm just going to pull up this slide with you here. So just looking at the dry blood spot test, so as I said, it's available for the PCR or the PCR RNA. So it basically uses a finger prick test and from the finger prick, it uses little blood droplets that are popped onto, as you can see on the right-hand side of the screen, that are popped onto a little bit of testing bit of paper. And it's non-invasive. And this is a really wonderful thing, as Ruth mentioned, as many people might have issues with venous access. They also might not want to be having someone draw blood. So it's great in that it's a super quick tool that you can use. You can use it in an outreach setting, for instance, if you're out and about with your clients. It's super accurate. So it's got something like a 95 to a 99% accuracy rating, which is very, very high. So just jumping ahead. If this is the website, the portal to be able to get into the dry blood spot test website, and basically there's a series of questions that look at eligibility in order for somebody to be able to you can either have the dry blood spot test sent to you at home, which is great because it can be anonymous, and the kit arrives in the post, or you can also if you are in a service, you can assist your clients. You can apply to be a registered site, and you can assist your clients with the test, which many services in New South Wales are now doing. So just looking at some of the eligibility criteria, Some of the eligibility criteria for the hepatitis C test are people that have been in prison, people who inject drugs, people from high-risk countries, some of those countries Ruth mentioned before, and Aboriginal and Torres Strait Islander people. I'm just going to stop the screen share for a moment and just step back so you can all see me. So this is what it arrives. This is what it looks like when it comes in the post. It's a great little kit, so you just open it up, and on the inside it's got some instructions, and then this is what comes in the kit. So you've got a return envelope, so once you've completed the test you can send it back in the return envelope. It's got the little testing card that I mentioned before, which looks like that. And then there's a couple of these little lancets, and it's basically you twist it to open and prick your finger and then drop the blood spot on the card here. So it's completely non-invasive. It's very quick to administer. You send it after waiting for it to dry. You send it off, and the results are delivered. They can be delivered via the Sexual Health Information Line, this SILS, within a couple of weeks. So they're sent off to the lab for testing, and then they come back. So it's a great little tool. It's really something that is being widely utilised now in our community. I think it's something like half of the tests, the dry blood spot tests that are being undertaken are through Justice Health in our prisons, and it's been super successful in the prisons. And also it's interesting to note that a number of different community organisations are now using dry blood spot test, which is great because it's something, apart from the local health districts, it's something that also community-based organisations can use as well because it is non-clinical. And I think we're going to be seeing more of that in the future. Many more community organisations in the alcohol and other drugs sector, community organisations working with Aboriginal people, community organisations that support people who are coming out of incarceration, using dry blood spot as a tool to be able to look at testing, and particularly for those harder to reach communities, and then moving towards treatment. The other really wonderful thing around dry blood spot testing is that you can also get, if for instance the confirmatory testing confirms that somebody has an active infection, SILS will also support the client into getting further, taking the next steps with treatment. So it really is a wraparound service. So if you haven't already, I really encourage you to take a look at the dry blood spot test website. And if you wanted to have a chat to Hepatitis New South Wales, we're also keen to support community organisations in, if they're interested in becoming a registered site, that's something that we'd be very keen to support you with. So thanks everyone. And I am going to hand over now to my colleague. Where are we? So who's up next? Kyle, that's you. Thanks.
Fab. Thanks so much, Alex. So as we've just heard there, we've heard about some of the ways that testing works. So testing is antibody test generally, does a screen as Alex and Ruth both talked about, and then moves into a PCR or an RNA test. And if that comes back as positive, I'm just going to look at some of the ways that the process takes on from there through into treatment. So Alex, if I could just have the first slide, please. So what we're going to look at here is the pre-treatment assessment. So it comes in a number of different sort of areas. One of those is looking at the liver and sort of the virus. And the other side is looking at the person and some of the sort of person factors. So there we are. So one of the things that we want to look at for a person going on to treatment is what's going on with their liver health at this point. So there's a few different ways that we do that. One of the ways that we do that is through a liver function test. And that gives us some idea of different sort of enzymes that are going through the body. Ruth did a fantastic talk there about what's going on in the liver and the way that it processes things, it creates things. One of the ways that we test exactly how that liver, how healthy it is through the liver function test. Liver function test will give us lots of information and we can use that in part of the pre-treatment assessment. One of the other ways that we look at the liver is through either one of a FibroScan or an APRI. Some of you might have heard of both of those, some of you might have heard of just one. FibroScan is a very, very non-invasive, really, really quick and fantastic tool that we've got in our arsenal. Very much like an ultrasound, gives a sort of scan on the side of a person's body, as Ruth pointed to, where your liver is, and it tells us what's going on with the liver at that point in time. Really, really great machine. But it's not widely accessible across New South Wales. It is quite an expensive piece of kit, and that's why we have the APRI score. So the APRI score, what that does is it takes two pieces of information, one from a liver function test and one from a full blood count, puts those into a little online calculator and gives us a little score again that we can tell what's going on with this person's liver and how healthy that person's liver is at that point in time. So that's one of the really, really important things that we want to look at with a pre-treatment assessment. And the reason for that is that cirrhosis, or people living with cirrhosis, need to be managed by a specialist, whereas everybody else can be managed under a general practitioner. Now, that's not a cut and dry rule. In some sort of regional and rural areas, GPs can manage patients with cirrhosis, but under very close supervision with a liver specialist, rather than sending someone a long, long way off to one of the hospitals generally where the liver specialists are. So one of the really, really important points there is that all of this can be done by a GP, which is a fantastic revolution in hepatitis C treatment, and all of these little pre-treatment tests and all the things that we're looking for can now all be done by a GP, which wasn't the case before. So that's really, really great news. And one of the really, really, I guess, important parts of that pre-testing and that pre-treatment assessment is that genotyping is now gone. So you might have heard about genotypes, the different strains of hepatitis C. That test has thankfully been taken out, and things are getting lots more simple. So just jump onto the next slide, please, Alex. So this one is the FibroScan machine. So as I said, it looks very much like an ultrasound and acts very much like an ultrasound, gives a person a score, which tells us pretty much instantly what's going on with that person's liver, how healthy it is, and then we can make that decision on where the treatment's going to take place. And the next slide, please. And the next slide is an APRI score. Very, very simple calculator. I can't do the maths myself. Thankfully, there's a little online calculator that does. And that way we can get an APRI score and determine whether a person needs to be managed by the GP or with a specialist. Next slide, please. So we've sort of talked and sort of mentioned little bits here, but one of the really amazing things that we've got in our arsenal now is these revolutionary new cures. And really it's a revolution on so many different fronts. It's a revolution on where a person can be treated, so at a GP and not having to be at a specialist. It's a revolution on access. Everybody can access hepatitis C treatment. It's a revolution on who can do treatment. There's no longer the stipulations on who can. And it's a revolution on the treatment experience. So just in the next slide, we'll jump through some of what these key points are. One of the most important things about this new treatment, or these new treatments, and there's been lots of different ones, lots of fancy names, there's drug names, and then there's brand names. Don't need to worry about too much what they are. What we have really is two frontline treatments now. One's called Epclusa, and the other's called Mavorep, and both are, as with all the treatments that are available now, incredibly effective at curing people of hepatitis C. So with 95 to 99% cure rate, which is absolutely fantastic compared to what we had with interferon, anywhere down at 50%, even sort of 10, 20% in the very early 90s with the very early interferon. We're up now at the sort of 95 to 99%, which is fantastic. It's also, as I said, available to everybody who has a Medicare or can access Medicare in Australia and over the age of 12. So it was 18 up until a few months ago, and it's now everybody over the age of 12, which is really, really great news. It's the cost of a regular script. So that looks at around about sort of $40 for generally, and for those who've got a healthcare card, somewhere around the $6 to $7 mark. It's usually an 8 or 12 week course of treatment. Again, much shorter than the old interferon, which was sort of 6 to 12 months. So in just 8 to 12 weeks, 95 to 99% of people are going to be cured of their hepatitis C, which is brilliant. I've talked there about interferon. Hopefully everybody has a bit of an idea of what interferon is or was. It was an old treatment for hepatitis C, which required injections once a week with some pretty heavy side effects and scared an awful lot of people off treatment, rightly so. Interferon is gone. It's in the dustbin of history. We never have to think about interferon anymore as a present treatment for hepatitis C, but it does have, unfortunately, a very long legacy. And one of the really, really good things about these new treatments is that they're super well tolerated. And that means really, really low chance of side effects. Some people do get side effects, and it would be unfair and wrong of us to say that it's a completely side effect-free treatment process. But the vast majority of people's experience is very, very few side effects, if any at all, which is really, really great news. So next slide, please, Alex. As I talked about, accessibility is one of the sort of revolutions that we've got in hepatitis C treatment. And that means that people who inject drugs, one of the biggest cohorts, as we saw with Ruth's slides earlier, can access hepatitis C treatment as easy as anybody else. And so that's very much a sort of thing that we're sort of touching on, the legacy of interferon. Back in the old interferon days, sometimes people who injected drugs weren't able to access hepatitis C treatment. Now we have what's called equal treatment access, and we have since day one, back in 2016, everybody can access hepatitis C treatment. So there's no restrictions for people who are in prison, which is one of the best areas that we're treating people at the moment, so with the highest numbers. People experiencing homelessness, people who are drinking heavily, people living with HIV, people living with hepatitis B, people with mental health issues. All of these people can now access hepatitis C treatment in the exact same way as everybody else, which is amazing. And then just lastly, there is no prioritization based on liver damage. That's very much a thing overseas. In some countries, people do require to have a little bit more fibrosis, even cirrhosis, before they can access Hep C treatment. We'll treat someone whether they've had Hep C for 6 months or whether they've had it for 30, 40 years. So it's a really, really amazing landscape that we've got in Australia for hepatitis C treatment. And next slide, please, Alex. So that all sounds really great and fantastic, but there are some sort of slight, I guess, concerns as we sort of move into the future. And one of those things that Sandy touched on earlier was that treatment numbers have been dropping off slightly, and sort of there's a considerable difference between 2016 to now. Treatment numbers are much, much lower. And it means that there's lots of people, as we saw, 120, 130,000 people still living with Hep C out there, and might be a little bit more difficult to reach, which is why we need you guys, and that's why we're doing this training, to bring you into the sort of circle and bring you into the elimination fold to join us. We're looking, as we've sort of talked about today, at 2028 as our elimination goal. We call it unemployment by 2028, Hepatitis New South Wales. That's our goal. But we really need you guys to be involved in this, because what we have is 120, 130,000 people left living with hepatitis C across Australia. Some of those people might not know about treatment. They might know about treatment and they might not be interested. They might think that it's the old interferon treatment, that it's going to be a really tough time. They might have experienced some really poor interactions with healthcare workers, and that was very much something that we do know with our community, that stigma and discrimination is a massive part of the barriers as to why people don't go forward and get treatment. And I think that, for me, is a great segue into what my colleague JD is going to jump in and talk about, which is stigma and discrimination for the community living with hepatitis C. Thanks so much.
Hi, everyone. Hello, voice. Just got a few things to unplug. Thanks for being here with us today. I'm happy that we're spending this time together. I've got the lucky awesome job. My name's JD, by the way. I'm a project worker here at Hepatitis New South Wales, and I also do peer support work. I'm lucky enough to introduce today one of our awesome peer support workers and a positive speaker, Grace Woods. And I know that Grace is here today. Hi, Grace, wherever you are. Thank you for being here double. And we're going to be watching a recording that Grace put together for us of her story and her journey, and some observations and some feelings around her story with Hep C. But just before we go forward and have a look at that, I was thinking, because it is World Hepatitis Awareness Week, I was just sort of thinking about discrimination and stigma. I think that all of us here today have been touched in different ways around that, either because of Hep C or perhaps there's other things that that you connect to personally with the whole idea of stigma and discrimination. Especially because I know that a lot of us here today work in healthcare in one way or another. Maybe you've been to some other webinars this week. I was at one earlier this week where they were showing some really interesting graphs. I never thought I'd say that sentence, a graph that's interesting. There you go, first time for everything. And one of the graphs was around stigma and discrimination. It was saying, you in the workplace, do you ever have stigma or discrimination towards your clients? And the graph was kind of like, no, not really, maybe sometimes. And then the next question was, do your colleagues or people you work with, do you ever see stigma and discrimination then? And then the other graph was like, this is like, oh yeah, definitely. Other people around me do that. So I thought that was a bit of an interesting discrepancy, and just sort of thought as we, and look, I'm going to out myself right now, actually, to be honest with you. My name's JD, and I think I judge sometimes. I think that no matter how hard I try, I do have some stigma and discrimination stuck in my head, the way I was brought up, some of the culture or society that I live in. But I think the big difference is catching it in your head and then going, oh, okay, that's my reaction. That's interesting. What do I choose to do about that next? And so I would, and that's a real challenge, to be honest with ourselves about that. That's why I thought that I might, if it's okay with you, just before we start Grace's story, her video, just to put it down to you as a gentle challenge to maybe watch this video just with a lens of kind of like, am I judging in any way with anything that's being said? Maybe even, do I connect with anything that's being said? Do I understand something that's being understood? Or perhaps I didn't realise that perhaps I've got a bit of stigma and discrimination with some of the things that are being said. Just to leave that with you. So we'll go and watch that now. Alex is going to start that off for us, and then I might just touch base with you on the other side. Thanks, gang. Thanks, Alex. So, for sharing your story with us. I almost kind of like forgot that I had to talk to you next, because I always find myself leaning right into Grace's story, and I can really relate to some of it myself, to be honest with you. I think I rung my mum the day that I found out too, actually. Thank you, Grace. And just with that, just with a little bit of a view to stigma and discrimination, Grace's story and Grace's journey, just at Hepatitis New South Wales here, we do have an awesome peer program, and a lot of our positive speakers like Grace are also peer support workers. We've got about 20 on the team doing various roles out in the community. And I just wanted to mention about how peers are such incredible people to kind of like combat, not just to help people, other clients get people tested in treatment and to help with that information, but just that really special quality that's really specialised around stigma and discrimination, because I think that so many of our peer workers and people that have been through the journey of Hep C have, from the front line, from the beginning, experienced what it's like to be at the cold face of really pretty hardcore different versions of stigma and discrimination. And I think that that's one of the most passionate driving reasons that a lot of our peer workers do this work. I actually talked to a couple of our peer workers and got some quotes from them. Let me tell you that some of the driving forces, the reasons that people do the peer work that they do is I find it really empowering for me. And I think that that comes a lot from their own personal story. Somebody else said, even if I just help one person that day, I know that I've made a difference. And this last quote is, it makes me feel like all the hard yards that I have been through are finally worth it. If I can help someone through what I've experienced, it makes it worthwhile, which I think is really powerful. And I just wanted to, just before I finish up too, just to remember also when it comes to stigma and discrimination, it's not just Hep C, the stigma and discrimination around that. There can often be a bit of a layered lasagna of discrimination. For example, there's already discrimination off the bat if you tell someone that you've got Hep C. But then it's kind of like, maybe you've got Hep C and you're a sex worker, you're a woman who has to go to get pick up your medication from an opioid dispensary. Perhaps you're homeless. Being Aboriginal and Torres Strait Islander, there's a lot of stigma around that too. Perhaps you've got mental health issues. It's very rare for one person just to have one of those issues. Often they kind of end up coming together, and with each one of those separately is its own stigma and discrimination. So if you start leveling them up, that's more of a weight to carry. So just for everybody to kind of like be aware of that today, I think, and I'd like to kind of like invite you to take that away in your pocket next time you're kind of like dealing with people from any of those backgrounds. And I was talking with one of my, a few of my colleagues recently, actually. Just wanted to leave you with this thought today, which is, if you are here today, that means that you are interested and do want to be part of the story of eliminating Hep C here in Australia. And we sort of figured that stigma and discrimination has never ever helped one single person get cured of Hep C. So if we don't address stigma and discrimination now, I don't think we'll ever really achieve elimination of Hep C in Australia. Something to think about. Thanks, guys. Thanks for spending time with us today. And I'm going to be handing over to Kyle now, who's going to be having a chat to us about referrals. Really important. Hey, Kyle.
Thanks so much, Jodie. So Alex, if you just pop that slide up, I'm just going to do a real quick look at some of the services that we've got at Hepatitis New South Wales. On the one hand, we do have a bunch of different resources. We've got a fantastic information and communications team producing all kinds of amazing resources out there. One of the other elements of the Hepatitis New South Wales website, which we encourage you to jump on, is our service directory. And it's a really fantastic way for people to work out what's in their area in terms of those fibre scans, doctors doing hepatitis C testing and treatment, liver specialists, hepatitis B specialists as well. A bunch of information on there. You just pop your address in and find out what you've got. But one of the other things that we wanted to sort of offer to people, especially in these COVID-dominated times, is a sort of personalised, get somebody cured service that we're trying to sort of get off the ground here at Hep New South Wales. And what that means is basically if you've got someone or if you're a person that wants to get hepatitis C testing, treatment, whatever it is, call us up and we'll make everything happen. So we've done this before and we're really hoping to do it in the future. An example of that was a gentleman that gave us a call a little while back from Lithgow. And at the time, Lithgow had no doctors anywhere in the area doing hepatitis C testing and treatment. And basically, yeah, we got the call from this person. They weren't able to travel great distances. It was over the mountains to the nearest doctor to get tested and get onto treatment. So what we did was we called up one of the local GP surgeries and basically just trained and taught the doctor the real simple process of getting a person tested and treated for Hep C. Took very little time. It's a really simple process. It's nothing GPs haven't done before. When we were able to get that person then into a doctor who knew what they were doing, got them tested, got them onto treatment, did it all under the supervision of that liver specialist over the other side of the mountains. And it really just meant that that person, that one single person, was able to get cured of Hep C. And JD sort of touched on that before. And I think it's really important point. It's about every single one individual person. And that's what we're really trying to hope to do with this service. So like I said, if you've got anybody that's, if it's one of your clients or if it's someone yourself, give us a call, get in touch, and we'll do everything in our power to get you through testing, treatment, and all the way to cure. And that's it for me. And I'm just going to hand over to Sandy to wrap things up for us.
Thank you, Kyle. Oh, that's just been, for me, it's just been so wonderful listening to the team. So, Alex, can you give me this slide, please? Clearing a path. So I started today off with saying that really what we're trying to do is actually, be myth busters really, and deliver no fake news and get the right messages out there. So get the messages out there that if you drink alcohol, you can still get DAA treatment. If you've got cirrhosis, you can still get DAA treatment. If the person's still injecting drugs, they can get DAA treatment. There's minimal side effects. It's simple. It's 8 or 12 weeks. treatment works 95 to 99%, as you've seen, as we've gone through today. So this campaign has been activated again during Hepatitis Awareness Week, and we've actually sent loads of materials out to all the local health districts to actually distribute through their NSP, needle and syringe programs, and drug health services in each of the LHDs. And we're really very, very happy to see this messaging continue in the market, because it's really important that these myths are once and for all busted, and that people actually, as JD was saying as well, that we break down stigma, discrimination, and people really are engaged in healthcare. We really hope this is part of the way. So you can see the imaging, you can see the imagery there, and it's really important. And just to recap as well, we have made fantastic progress in elimination, but as everyone has said today, including myself at the opening, we have actually seen a decline in treatment initiations each month. And obviously COVID has been, you know, a bit of a bump in the road, probably a fairly big bump in the road in this regard, with limited outreach screening and things. So as I did say earlier as well, we're really going to have to work together and draw together to actually reach these elimination targets. And we've been successful thus far. I have no reason to believe that we won't be successful moving forward, but as long as we actually move to work together. Alex, next slide, please. So these are 5 take-home messages. So I'm not going to read through them all, but, you know, just very simply, you've got bust myths. So we talked about that. I just talked about that now. Encourage testing. Really be open to engaging people to actually encourage testing, and reinforcing that people can get treated as many times as they like and tested as many times as they like, if they feel that they may have actually placed themselves at risk. So it's really important to have those conversations, and as JD said as well, you know, with that reminder of actually having that non-judgmental lens on and engage someone in an actually really respectful and meaningful way. Encourage access to treatment. Goodness gracious, we don't have many viruses, or many diseases for that matter, that actually offer a 95 to 99% cure. So it's so exciting, and it really is surprising that every GP in the country isn't wanting to work with this group of people when you can actually have such a high cure rate. Address stigma, discrimination, absolutely. And harm reduction as well. We didn't really talk a lot about that, but needle and syringe programs are vitally important. For every $1 spent an investment in a needle or syringe program, we actually save $4. So it's a really economically sound harm reduction measure, and it's really a good idea to try and I know where NSP services and those types of facilities to get sterile injection equipment in your LHD and service area are, so you can actually direct people to that. So I just want to finish by saying, I've got a bit of a note here, so I might look down. So thank you, Alex. Look, COVID, I know I've mentioned COVID a bit, but honestly, I check my app every day to see where we're at, but, you know, how many new cases, and I'm dreadfully upset about Melbourne, as we all are in Victoria. And anyway, we won't go on there because it'll just make us all too sad. But one thing that COVID has actually done is basically it's brought us all together, and it's brought really the sector together, and the sector together in this visual way of these online platforms that we haven't done in the past, and we've really enjoyed it. And it's like, oh my goodness, why weren't we doing this in the past? So I think that's a great thing, and I think that will be something that's sustained, where we can actually really work together from remote areas and make a difference, and really devise good strategies. I do want to just talk a little bit about what Greg Dorr said on Tuesday as well. So Greg did emphasise, and the team have actually talked about this today as well, that you know, it's important that we move away from antibody testing, because it is, you know, it's another stumbling block to some extent. It's not as simple as it could be. So we're looking at a lot of point of care, so fingerprint testing, rapid testing, so rapid results moving forward. DBS is also important. And Greg also talked about the importance of, you know, workforce development and peer-based programs, and peers out in the community engaging with people where they're at to help them access the healthcare they need is vitally important, and we play a really big role in that. And one of our flagship programs, Live Hep C Free, which Kyle is a coordinator of, certainly does that. And Carla as well, Carla Trelaw from Centre for Social Research again as well on Tuesday spoke to establishing a community of practice, which is just fantastic. And she talked about galvanising expertise across the state and country to determine what programs and activities are scalable for maximum impact. So these are the sorts of things, I agree with it completely. These are the sorts of conversations we need to be having. These are the sorts of things we need to be able to do to actually make sure that we actually are providing equitable and healthcare across the state. And we probably have to, you know, get creative in some of our ideas as we're navigating this COVID landscape. Personally, I agree that harnessing expertise and commitment across the sector will go a long way toward reaching Elimination C targets by 2028. So I'd like to thank you all for coming here today. We are on 3:18. That means we have a few minutes for questions. So we can actually unmute everyone now, Alex. And I'd just like to extend my thanks to my colleagues that have actually presented today as well. It's been a really tremendous team activity, as well as the external partners I mentioned earlier. And Alex has done a superb job on the technical side of things, and it's been seamless. So well done. So please, everyone, thank you.
Yeah, and just another quick shout out to Grace too. Thanks so much for being part. Double time. Appreciate it.
Thanks, Sandy. What we might do, if people want to ask a question, by all means, just unmute yourself rather than simultaneously unmuting 60 people, which could be a disaster.
Okay. Thank you. I don't think, yeah.
Thanks, JD. No worries.
Awesome. Hi, Grace.
Hello. Hi, can you hear me?
Yes.
Yes.
Yes, my name is Nargis Abram. I'm from Drug and Alcohol Services, Nepean Hospital. Thanks for the beautiful presentation, and especially the story which Grace have shared it. I really want to thank her from bottom of my heart, because it's very important to know from the patient journey perspective. I just would like to, I think I just sent it in the chat to, is it possible to, you can send us the PowerPoint presentation which been presented today?
So we have actually recorded this today. And so the recording will be available, and we're certainly going to share that with all our LHD partners and the guest list today. So yes, you will actually have the video of the presentation today to share.
Okay, so is it all right that if we can share it with our multidisciplinary team?
Yes, yes.
There is a testimony or there is a patient story from Grace. Is it okay with her if we can just share it with multidisciplinary team?
Yep.
There is, because can you actually contact us, because there is a bit of a process involved in that.
Mm-hmm. Okay, so we shouldn't be sharing that story with the rest of the team.
No, not at this stage.
That's what I thought.
Yeah, that's right. So that will be edited. So of the version that we're actually filming and sending around, Grace's video clip will be
Taken out.
Yes.
Yeah. Okay.
Yeah.
All right. Thank you.
But if you are interested in that, do keep in touch, and we can give you kind of like maybe a bit of a better quality version if we can get that happening.
Okay. Thank you.
Yeah, keep in touch.
Thanks.
There's a question in the chat box, and the question is, what does the picture look like for Aboriginal people and communities in regards to transmission, testing, uptake and return rate of DBS treatment, etc.?
Interesting. That's an interesting question. So Greg Daw was actually talking about this on Tuesday and looking at equity of access to GAA treatments. And he was saying that, which was really, really encouraging, that we're actually going quite well in that regard. So Aboriginal and Torres Strait Islander people are accessing treatment, which is really really positive. There's still a disproportionately high burden of hepatitis C among Aboriginal and Torres Strait Islander people, but obviously local health services and AMS are actually really working very hard to try and engage with their communities to get the message out. And I think it's also very positive that we've seen the change in ages at which GAS can be prescribed. So if there's any Aboriginal youth that are now impacted by hepatitis C, they'll be to be treated, which I think is a really, really positive step.
Thanks, Sandy. There's a question in the chat box which asks, can people be treated based on DBS treatment, the dry blood spot, which I'm assuming means test results, or do they require further venous blood drawn? Just to clarify that they do. So no, you need confirmatory testing if your results are active or positive.
Because there's a whole range of blood workups that need to occur as a result of having a positive test. So as Kyle, maybe you want to talk to that.
It's just that DBS is just a pilot at the moment, so it's not part of the sort of formal health structure. So we can't use it at the moment for sort of being diagnostic, but hopefully in the future that will be part of the tools. It's just going through the pilot sort of study at the moment, and just checking that it all works and it's all effective, which is showing overwhelmingly to be. So in the future, yes, we're really hoping that that's part of the tools. But at this point in time, yeah, that person does, if they get the positive result from the DBS test, they do need to go back and get a traditional blood draw, which, yeah, is through venous access, unfortunately.
There's, I'd like to add onto that as well. This question came up when we were talking with Sinead, who works over at the liver clinic at RPA, and she, her and Sue Mason were instrumental in setting up a specific clinic around difficult to access venous blood draw, which quite groundbreaking, because it can be a really traumatic experience for somebody to have that procedure done, and can be real off-putting for accessing treatment. So if DBS comes back reactive, then there are options, not just about trying to push somebody into a pathology lab, but there are options for specialised care for people who might have difficult to access veins. And that could be just one blood draw, not multiple blood draws, and that could be given extra care for that treatment.
Yeah. Thanks, Ruth. Do we have any other questions this afternoon? Well, in that case, I think we can actually, everyone can have a 5-minute early mark.
Woo! Yay!
Thank you.
Thanks, Sandy.
Well, you never really expect when you're doing one of these things for the first time, you're going to have an early mark. But I promise I won't waffle on for the next 5 minutes and fill up that time. But again, thank you very, very much for joining us today. It's been an absolute pleasure and delight to see you all. We'll be doing more of these, and we'll be seeing you again, and we will send the evaluation survey out a little bit later today, or first thing tomorrow morning. Please, respond to that. It'll be really, really helpful for us. And again, if you've got any ideas or things you'd like to hear, please let us know and we'll make it happen. We're going to start doing these in earnest, so it's all very, and particularly now I know that we can do it so well. Anyway, I jest. And Grace Woods, thank you very much for your beautiful story that has been so beautifully captured, and for also attending in person. We're really grateful. Just to let you know, we were having a bit of difficulty with the sound. So even though it looked like it was flawless, technically it wasn't up until a minute before we were starting today. So yeah, we pulled it off, and we ended up being able to hear Grace perfectly. So that was wonderful. So again, thank you, and have a lovely afternoon.
Bye, everybody.
Bye.
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 Bye.